एक 2 मिनिटं थांबा. लगेच कॉल करू.
Topics are all common topics that we've all probably read in our pediatric theory as postgraduate students. But yet, when we come across these cases in our routine day to day office practice, there is a lot of confounding, there's a lot of confusion on what to do at that spur of moment. So, such topics are selected where we have exclusive experts who come in and guide us to go ahead with these things. And of course, for the sessions also, we have our exceptional moderators. So, we have Dr. Samir Dalwai, who is Zaraa Hatke, and today, Samir Dalwai from IAP Mumbai is at IAP Chiplun. So we have our pediatrician friends from IAP Chiplun there sitting behind. And we have Dr. Nitin Shah sir, all-time favorite. And I will say he's the Zaraa Bachke part of Zaraa Hatke, Zaraa Bachke. Because he will come up with that ex-tempo, any kind of questions that'll just be flashed. And actually, we have to start thinking that, what to do next. So I think without wasting much time, we go ahead and we begin with the session. And I invite both our esteemed moderators today to please also introduce our exceptional experts for today's session and go ahead and start the session. Thank you so much.
Samir, go ahead.
Thank you, Dr. Nehal, and good evening to everybody. Forbidden licks, sips, and sniffs. People might wonder what exactly are we discussing, but don't worry, we are just sticking to accidental poisoning in children. And even somebody who doesn't write many medications as a developmental pediatrician, I've had those more than occasional cases of children who had an extra dose of risperidone and then land up in some kind of a complication. I'm very happy today. Mumbai Connect is expanding, and today we can add Mumbai Connect and Chiplun Connect, because I'm at my native place. I come from Chiplun, and here you see all the pediatricians from Chiplun who've gathered here today to be part of this Connect. And as you all are aware, the topics are always something Zaraa Hatke, Zaraa Bachke, because these are topics not usually discussed in the routine care, in the routine conferences. But we have to be Zaraa Bachke because they can always come back to haunt you if you are not very careful about it. So coming to intensive care and poisonings and children ending up with the problems, we have with us today my co-moderator, the one and only Dr. Nitin Shah, who absolutely does not need any introduction. He is the most intelligent, the most charming, and the most person who can ask you the most pointed questions. And if you can't answer, he will answer them as well. So he's our moderator today. But we have a fabulous panel. And the first person on the panel that I have the pleasure to introduce is our teacher, Dr. Sunu Udani ma'am. She's a fellow of the Indian Society of Critical Medicine, life member with IAP, of course. Hands-on experience in pediatrics has made her gain recognition in the field of pediatrics and childcare. She's a fellow of the Indian College of Critical Care. And many achievements. National convener of GEM course of IAP, recognized as teacher with DNB Pediatrics since 2009. Served as a faculty for advanced pediatric intensive care course, at present medical director and head of pediatric critical care and emergency services at SRCC Children's Hospital, managed by Narayana Health, Mumbai. She has spent a lifetime to the development and implementation of critical care in the city and country. And many of the intensivists who are attending this program today are her students, I'm sure. Multiple publications, and won the Lifetime Achievement Award of IAP Mumbai just in the last few months. So very happy to have your presence here with us. Welcome, Dr. Sunu Udani ma'am.
Thank you.
I must tell you, she's Dr. Sunnu. She doesn't like Sonu.
Dr. Sunu Udani, welcome to
Forget that now, Nitin. I'm so used to it.
That's why I said you have to be Zaraa Hatke and Zaraa Bachke with Nitin Shah. Okay, all right. I'm also very happy to have one of the most respected intensivists, and who's also a very dear friend of mine, the quite unassuming but very knowledgeable Dr. Mihir Sarkar. And he is an MD Pediatrics, of course, professor and head of the Intensive Pediatric Care Unit at the Medical College, Kolkata. And he has been a teacher of the College of Pediatric Critical Care. He is a Pumanchal Pioneer Award winner of 2019, Secretary, West Bengal Academy of Pediatrics, Chairperson of the Society of Pediatric Intensive Care, Kolkata, Vice President, Pedistar, India, more than 50 publications, 28 international ones, and lung ultrasound, advanced hemodynamic monitoring, non-invasive ventilation are issues and topics where he has been working a lot. And we are very happy to have you with us. Mir Bhai, welcome to you. We also have with us Dr. Anupama Yera, who is a fellow in pediatric critical care. She is a senior pediatric consultant, pediatric intensivist, and pediatrician, Rainbow Children's Hospital from Hyderabad, India. She has done her clinical observership in Gosh in King's College London to gain expertise in managing complex congenital heart diseases. 15 years of experience in pediatric critical care, having worked in Rainbow Hospital since 2015, has been a DNB accredited pediatric care teacher, and areas of interest include pediatric sepsis, ARDS, and I hope poisonings. Welcome to you, Dr. Anupama.
Thank you, sir. Thank you.
Thank you. So very, very nice to have all of you here. And we have more than 100 participants, I would say, who are also going to be equal contributors in today's discussion. There might have been a slight problem with the link. So those of you who have joined, please, while you are listening to this wonderful discussion, make sure you forward this link to a few other friends who may not have been able to join in. So with this, it's over to respected Dr. Nitin Shah, sir, to take the discussion ahead. Thank you so much.
Thank you, Samir, and welcome all the delegates who have spared their time on a valuable night to learn something about poisoning. And I always like the titles given by this young lady brigade at the IAP Mumbai. And not only the title of the main webinar, but each episode is really very aptly titled. So today, when we discuss poisoning, the plan is that for first half an hour, we will discuss about general approach to poisoning, because we only read the books, the poisons, and the patient don't read the book and come. So when a patient comes, we don't know what poison it is many times, especially young child who could have eaten anything at home. So we'll take the approach to unknown poisoning and management, etc. And then we will take some specific poisons which are commonly seen in our day-to-day practice, and we can take as many as we can, because sky is the limit. There are hundreds of such poisons which can affect anyone. So, starting with Dr. Sunnu Udani, what we will discuss in the approach to poisoning is the general principles about an unknown poisoning, how one can come to zero down as to what likely the poison is. How do you look at those what are known as toxidromes or the syndromes of toxicology, and then look at the general examination and the history and put the jigsaws together to come to conclusion as to what could be the poison, and then come general management and how can we get help when we are in difficulty with a known or unknown poisoning. So, Dr. Sunnu, I mean, when do you suspect poisoning in a child who is not behaving as per what you think is a presentation of a typical disease?
Yeah, exactly that. That when it doesn't fit into something. For example, someone who's unconscious, we always think of an encephalopathy. But the pattern of unconsciousness may be another metabolic issue like acidosis, something that just doesn't fit. Why should an unconscious child be severely acidotic?
Correct.
So things that don't fit into a particular diagnosis. For example, we had a child with multi-organ failure. Now,
Correct.
in intensive care units, we are very used to having children who come with multi-organ failure. But he was deeply unconscious.
Correct.
MRI didn't show anything. Nothing showed anything except that he was in severe multi-organ failure and there was acidosis. And we put, just putting things together, we realized that he had ethylene glycol poisoning from cough syrup. And this we proved by sending it to Chandigarh, where she very generously did the level for us. So if something doesn't fit, we need to look at something else. So the five whys of this are: why is this happening? What is actually happening? Who is it happening to? And, if it's happening to a small child, you think of things that are at the level of the child. If it's happening to a teenager, you think of a possibility that the teenager may have actually done something, or it may not be accidental, it may be intentional. So that's very important. And where? Where was the child when it happened? Was he outdoors? Was he playing? Was he in the house? Was he in the kitchen? So the where is also very, very important. And gather all the medicines in the house and bring them. That is also very important.
Right. So sudden altered mental status patient, suddenly hypotension, suddenly hypertension, suddenly agitated, suddenly drowsy. Remember when we were small, when we were we were students in the medical college. Typical small child is brought at night, 2 o'clock. He's not breathing, he's not moving, and you see a severely miotic a pupil, and you know it's all nothing else but some opioid given by the parents unknowingly or unknowingly. So these are the types of manifestation that will bring, and of course, at risk. Children who are at risk, very small children below 4 years at risk of accidental putting something in the mouth, and adolescents, as Dr. Sunu said, are at risk for intentional or a poisoning because of a suicidal tendency. So liquids are mistaken as water, like kerosene is put in a white bottle, or vinegar. I have sent children, people opening a fridge and thinking a cold water and just drink some vinegar or a mosquito repellent and thing like that. So last but not the least, of course, some spurious medicine. I mean, we won't blame any pathy, but spurious medicine, let's say, which can lead to a chronic or an acute accidental poisoning. So now, having the acute poisoning as a suspect, Dr. Mihir, maybe you can throw lights on what are these toxic dromes, or what are the syndromes which will help you to zero down as to what the likely possibilities. So how does one go about achieving? I mean, if the history the child took the father's antidepressant or antihypertensive, it become very easy. Just look at the pill count and you know how much the child is taken, etc. But many times they don't know what the child is taken.
Yes. So thank you, sir. So this is a very important questions, because as Madam has already said, this unexplained, the puzzling combination of symptoms with the patient with multiple system involvement that we cannot fit into the typical disease pattern, that we always think about the toxins. But having said that, there are, I think, more than thousands of toxin, the poison, maybe there are each and every drug, if it is taken in a abnormal dose, can act like a toxin. So how we can identify with these thousands of drugs the typical pattern that we sometimes may follow, that can be helpful but not always. These are that we called as toxidromes. So the constellation of the signs and symptoms, like the few are the divided, like the sympathetic, few are anticholinergic, few are cholinergic, few are opioids and sedatives, and nowadays this the serotoninergic. So if you look at this these parameters, I'm trying to first with the sympathomimetics, like the bicyclic and
So let's take the first toxidrome as excitatory. The child is excited, everything is up. Just give some examples and how will you zero down?
Yeah, so everything is up. That is the heart rate. The child is tachycardic, child is hypertensive, the dry. So that will be the sympathetic stimulation is caused. So tricyclic activity. So this would be the causes. If the child is very wet, like this is a lot of secretion, there is a lot of this chest congestion is there. There is urination or the defecation. So diarrhea is there, emesis is there, then it is the fitting with this anticholinergics one, like this organophosphate poisoning, the
poisoning, right.
poisoning, carbamate poisoning. So these are the fitting to this. And other thing is that the child is these are very hallucinating, this combative, when you say this combating, very dry, this temperature is high, this tachycardia, and along with that, there is the mydriasis, these people are dilated. Then these are coming in the fitting with this anticholinergics, like the atropine, the dhatura. So these are the groups of drugs.
Even the drugs like LSD and the substance abuse can come like similar hallucinations. Yes.
Hallucination, yes.
Nystagmus also will be possibly seen in such patients.
Yes.
Right.
And if everything is down, then the child is totally sedated, this hypotensive, or this bradycardia. There are two possibilities. Either it is going to these sedatives like benzodiazepines, anything related to the benzodiazepines, or the opioids, like maybe the heroin or the other opioids, maybe toxicity. The difference we can make is that we get the pupil. If you look at the pupil in opioid, it will be the pupil will be the meiosis will be there. But benzodiazepines, there will be no such change in the pupil. Yes, madam.
Just add one thing.
Yes, Dr. Sunu.
Don't waste time trying to figure out and rack your brains about what the poison is. Treat the patient, not the poison. That's very important.
So we'll take
get lost in that,
Right. So the emergency management should simultaneously happen, and someone else can actually plot into these
Exactly.
detoxidromes and find out what's poison. Someone else can collect samples in sand and things like that, and then try to. So I completely agree. Don't waste time. Like any sick patient, first is to manage because survival is important, and then comes the etiology and if there is a specific antidote. Dr. Sarkar, continue. You were saying about inhibitory. You said sedative hypnotics like barbiturate or benzodiazepine, alcohol.
Yes.
They will all come with everything low.
So, is there any
Yes.
role for lavage here?
So we'll come to that general management in a minute, Dr. Samir. Let's go to Dr. Anupama. Dr. Anupama, order is a very important way of finding out some poisons. So can you give some example of specific order and what do you think of?
I think
Like I'll say fruity order, acetone-like order.
yes, one common order which we always in emergency room is organophosphorus poisoning.
Mhm,
So many times we see children who are very drowsy, pinpoint pupils, and
mhm.
then very classy order is the organophosphorus poisoning which we uh, pick up in the emergency room. Others,
That's
as you
garlic-like. It's a
Garlic
yes,
like.
garlic-like.
garlic like yes,
Right.
yes,
If
and
you have
then
a very
especially
sweet smell that you also like, "Arey wow, what a smell," but
yes,
child is poison.
But
What do you
yes,
think of?
yes,
always, I think we need to remember that many of these things that people take are mixed with other things.
yes,
Absolutely.
Yes.
So the
yes,
Very
yes.
true.
kerosene may overpower the garlic
Combination.
odor. So
God,
don't
yes,
just,
yes,
Right.
yeah.
Okay.
yeah,
Many time mixed
So,
poisoning may be there. Yes, I agree.
right. So,
yes.
like, suppose you have bitter almond like smell, which is common, or you
Uh,
get think of cyanide or some such
Cyanide, yes,
poisoning.
yes, but
Yes.
Probably
not
won't
so common.
to tell
Yes,
you that
Very
yes,
specific will be in children mothballs. They take
yes,
the mothball
yes,
and they can
naphthalene,
smell
Naphthalene.
of naphthalene. Everyone knows
naphthalene.
naphthalene, yes,
mothball. Our old blankets which you take out, they are put with mothball inside. You know the smell of the mothball.
yes, yes.
Kerosene, of course, will be so easy because it
Easy
will.
to find out.
I get extremely worried even when I was student. Say the mother would say, "बच्चे को बुखार था, उसको थोड़ा kerosene पिला दिया." Then my kerosene दिया कि kerosene दिया. Then of course the poor woman means kerosene, but then you get a little heartbeat which is missing. Okay, anything which is like balm, which is salicylate, and rotten eggs is what they say. Anything which has
Yes,
sulfite. So these
yes.
are the different orders which can help you to zero down. Now you are managing. You are talking about general management. Samir, take forward. What are the points in general management in any poisoning, known or unknown? You are muted, Dr. Samir.
Right. So when you get a call in the middle of the night, like Sir said, and you go into these and you have your RMO there, what are the first things you're expecting that the RMO is already done by the time you are there?
Sunu, maybe you can take this.
Yeah.
You know, I think the worst thing that the RMO can do is an immediate gastric lavage because
Yes,
now more and more we are against gastric lavage. And
Correct.
even in certain poisonings where gastric lavage will work, it will only work in the first half an hour, 20 minutes of the poisoning, which is
Mhm.
really not the time that they will come to you. But any
Mhm.
corrosives, any hydrocarbon, anything like that, in so many of them now we know that gastric lavage is contraindicated. So
Contraindicated.
one of the things we actually don't do nowadays is gastric lavage. Another
So
thing
just
that we
before you go, one subsidiary question: do you have to do it to collect sample for sending for medical legal issues, or that's not required now?
no, medical legal issue does not require you to do
Okay,
a gastric lavage. You have to
fine,
do what is right for the patient.
perfect,
If there is vomitus or something, you could collect that. But
correct,
don't do an active gastric lavage, except in very few conditions.
correct.
And those conditions are actually hard to treat most of the time. Because
Okay.
very often corrosives and all, they try to dilute it, they try to do a gastric lavage. No. Find
Yeah.
out the timing as much as possible because
Mm.
that can save a life. If you can get the timing right and you can see. Another thing that you must do, especially in tricyclics or adolescents and beta blockers or anything like that, is an ECG. So
Mm.
these simple things can tell you a lot.
Correct.
And of course, treat the patient. If the patient is hypotensive, chart that. Look at
Wo-
a good blood gas. Look at the lactate. Look at the acidosis. Because most, rather than alkalosis, they will give you an acidosis. Even
Correct.
salicylate, very early on, it will give you an alkalosis. Otherwise, it will almost always be acidosis.
What
And
about what about emetics?
absolutely not.
Absolutely
Correct.
not.
Absolutely not.
So I
Absolutely
think
not.
all that
You
we
know,
have learned as residents, we have to unlearn that you
Unlearn,
don't need
yeah,
gastric
yeah.
lavage unless someone has specifically said, I have consumed 20 tablets of diazepam just 15
Half
minutes
an hour
before,
ago,
and
yeah.
someone has come running, maybe you can try it,
So
but
there
definitely
is a
not.
place for charcoal. There is a
Correct.
place for activated
So
charcoal.
how do you get the activated charcoal, Dr. Mihir? I mean, and is it easily available? What's the cost? And if it's not available, what do you do?
Yes, so it is not always readily available in the pharmacy, but in our hospital we have made a stock. But yes, there are limited use of it. Again, the same thing that we don't have to think about the poison. First, think about the patient. So we are treating the patient. So first of all, if the patient is unstable, stabilize the airway, give the breathing support, give the circulatory support. Then, as the madam has said, that if the airway is maintained and patient within the 1 or 2 hours of the this particular poison, then that can be
Someone can mute everyone else, please. Yeah,
Yes.
go ahead. Sorry.
And absolutely no for this corrosives, for the kerosene, for the heavy metals, and these are the absolute no for the charcoal. And like the paracetamol poisoning as one of the that is maybe fatal. So this thing when you can start early organophosphate if the patient is airway is maintained, or after maintaining the airway within the 1 hour patient is presenting, there are some role of the activated charcoal.
Okay, but if it's not available, you need not break your head.
Yes, no.
How does it work?
It actually have a great surface area, so it just absorb the poison which is in the stomach in between. But if it passes through the stomach, then it cannot lay.
But suppose you have some agent like opioid which can actually delay gastric emptying. Can you be a little more flexible in your gastric aspirate? And I think the admin, someone needs to mute everyone and not allow them to unmute, please.
Yeah, can you please unmute everybody? Mute
Then
everybody.
mute
Neha.
everybody.
Mute everybody.
We've
And
talked
also,
about
there's a break.
organophosphorus and
No,
Sorry,
kerosene.
yeah, go ahead.
Zara.
Sunu.
Oh, we've talked about organophosphorus and kerosene, but one very important thing we've forgotten is decontamination.
Yes.
That decontamination is a small part, but very often they spill it on them. The insecticide vapor may be on them. So strip all the clothes off.
Correct.
And
Wash them
give
off.
the kid a bath.
Watched
Yeah.
it. Yes,
Absolutely.
yes.
All right.
And
Is there
eye
any?
is important. Irrigation of eye is also important because
Yes.
sometimes we get
Yeah.
skin
Dr.
and eye.
Anupama.
Yes, sir.
So specific antidotes available, which you should always have in a tertiary care ICU, especially because you can
Yes,
get
yes.
poisoning anytime. And is
Yes.
there a role of an empirical antidote,
No.
say like naloxone in someone who's come with a severe meiosis or smelling
If,
of like?
yeah, if
go ahead.
if you are able to at the emergency room, if you are able to understand what toxidrome is, yes, then. But then, as everyone said, Dr. Sonu ma'am has said, and me said, first important is to stabilize the patient, which is
All that is done. We
Yes.
said that we do ABC, we send blood gas, they've done electrolytes, we've done
Yes,
organ
yes.
specific tests.
So if you
You manage the
fit into
hypotension. Now question
if it's-
comes, what next?
Yeah, if you fit into specific or toxidrome like organophosphorus poisoning, yes, you can consider an atropine. Or if like as we thought about like sedatives, yes, you can consider, or hypnotics, you can think of an naloxone. But if the child fits into a specific toxidrome, but until you stabilize the ABC, and then only you'll be able to identify what toxidrome this child is fitting into.
Okay.
One thing
Manage.
about naloxone, Nitin,
Yes.
it can, first of all, it's not dangerous to give. So yeah, if you're expecting, you give it. But remember, it is not actually an antidote or a treatment because it might help you diagnose if the child wakes up. But you still need to support the child because the naloxone effect will wear off, but that side effect will still be there.
Yes.
So one dose of naloxone is not going to do the trick.
Correct. So you need to
might have
give
give a
repeated
JP,
doses.
yeah.
Yeah.
It will help you
Is it-
diagnose.
Yeah, correct. Absolutely right. And so manage the hypoglycemia, hypothermia, hypertension, hypotension, electrolyte disturbance, arrhythmia, all that is done. And then you try to give the specific antidote if it's possible. One important thing is that the child could have also had a trauma.
Yes.
It might have fallen after poisoning. And so when you are intubating or something, you have to be careful about, is there a spine injury? Don't try to do too much of heroic measures. Otherwise, you can land into trouble. Anything else in the general management that you will want to? Achha, one thing, is what samples to send in an unknown poisoning, Dr. Sunu?
You know,
Or
No,
Dr. Anupama, whosoever. I mean, doesn't matter.
Basically the blood, urine, and the gastric aspirate. Always better to collect and keep.
Mhm.
And whenever you suspect a poisoning, when you look at the initial clinical presentation.
How early, Dr. Sunu, you get your results back?
no. In fact, I was going to say that it's useless because
Correct.
one of the things is that our panels are very limited. We
Yes.
have in Bombay only an opioid panel which gives benzodiazepines and opioid. We don't really, paracetamol, you will get the result the next morning. So if you know and send, it's one thing. But you know that opioid panel and those other panels are like 20,000 each.
Mhm.
So I
So they
find
are,
that it's not
We-
going to be
so
very useful.
if I say that they are,
We send
Like
to Amrita
Anupama said, I would collect the sample and keep
samples.
it and decide
yeah,
to send it.
Dr. Anupama, you want to say, add
Yeah,
something?
so what ma'am is saying is absolutely right. So it's very difficult in-house in your city to get the poison to be detected from the common available, commercial available tests. So we generally
Correct.
send to Amrita Cochin, and
Mhm.
based on the toxidrome and the history, circumstantial evidence, we start, if it is a poisoning, you address it.
So how
And
fast they give you the report? That's the
they
question.
take 4-5 days, sir, because sample has to be them.
So is it correct to say, all three of the experts, that if you have an unknown toxin which is poisoning the child chronically, and
It-
then your time at
It's
hand,
more important. Yeah.
then it's probably more useful. Like you have
Yes.
thallium poisoning, Dr. Snu will remember the entire family in Hinduja,
Remember them?
or someone has some
Yes,
rare
that
toxin
was.
like lead or arsenic given on a chronic basis, then those are the places where this toxic screen will be more useful. Even if it takes 3-4 days, you know what is it.
Yeah,
Or
I have.
recurrent.
Yeah,
Someone comes with recurrent, odd-looking
Rec-
symptoms.
Recurring
Someone is
organism.
poisoning the
Yeah.
child.
Yes.
So one
Yes.
thing is that if it is the for medical legal purpose, if you're informing the police, you have to keep the sample because you have to hand over the it to the police, and it is our duty as a doctor to keep the sample, either blood or the urine or vomitus or gastric lavas, whatever. And you have to inform the police and take the information of the patient, and you have to have a duty to keep it up to 3 weeks. And you have to
Correct.
again inform, if they are not collecting you, then you have to again inform you, the police. And
Correct.
before discarding it, again, you have to get the final information. Otherwise, we as a doctor may be a problem later on if there's something, the homicidal things is coming out later on.
Correct. So can we resolve to say that number one, collect the vomitus if it's there. If you've done a gastric lavage, keep that sample. Urine and blood, keep a sample. If you have an in-house, like for specific poison like iron or paracetamol, they are ready to give you in a few hours time. Okay, send it. Otherwise, keep them. Treat the patient based on your clinical judgment rather than waiting for the report. In a chronic patient, yes, do send those toxic screen, especially if they're coming recurrent with odd symptoms, as Dr. Sunu said. It may help you to zero down on a particular poison, and then you target that poison for treatment. But your acute management in the first 24 hours should be based on your clinical toxidromes rather than trying to wait for the blood reports or
And
urine
don't
reports.
think you know it all.
Yes.
Get help, look up the books, and even call the poison center.
All right.
Hinduja
So
is
that,
quite a decent poison center, and
yeah.
AIMS has a good poison center.
Correct. So that was my
So
question.
call
Which
the
are the
poison
centers?
center and
Yes.
read the books. Open the books. No
Right.
harm. We can't know everything.
So one is AIMS, which is the other one you said?
Hinduja has a poison center.
Hinduja has,
They
yes.
give-
And then
they give
what?
advice also.
Okay, toxicology books.
Books, open the books.
Amrita also has.
Amrita has fourth,
Amrita
and
has.
then maybe some very up-to-date like program which are
Yeah.
really up-to-date. They will give you a lot of information on every poison, and that will help you. All right, so that's where we end the general management. Anything else? Otherwise, we'll take some specific poison. And actually, Samir, you can take the first one, hydrocarbons. Unmute, Samir.
So go ahead. I have a network issue here. So go
Yeah, okay, all right. Oh, okay, fine.
Yeah, you, Samir.
Okay, so Dr. Sunu, as I said, बच्चे को थोड़ा kerosene पिला दिया. Of course, that is kerosene, but kerosene is something mistaken as a liquid which is colorless. A child may drink it. So, I mean, how do you manage a kerosene poisoning?
See, from 30, 40 years that I've been practicing, or maybe, we dreaded kerosene poisoning like nothing else because those
Yes.
kids would die. We'd go to their autopsies and their lungs looked like someone had actually torn paper and thrown those lungs in.
Correct.
Today, the picture has come quite different because we have good ventilatory management. We can sort it out. So
Correct.
kerosene poisoning is not just the lungs. It can
Correct.
affect the brain. They can get seizures. The least important thing is the GI tract. They get diarrhea, etc.
And lungs.
And so lungs are the most important. They give the maximum trouble. CNS we can only support by anti-epileptics, anti-edema measures. So
Correct.
as far as the lungs are concerned, don't treat them exactly like an ARDS because these lungs are very, very friable. And I would say that one of the things in these lungs would be to give early ECMO.
So
Because
it
if
may
you
take
give
few
early
hours.
ECMO,
It may take few hours before the chest signs may come, and an X-ray may show a
yeah. So the
consolidation.
dictum is that if there are no respiratory symptoms after 8 hours, you can actually discharge the child.
Absolutely.
But otherwise, keep the child, watch the child, and treat it. But do not be very aggressive in your ventilation.
Correct.
They
So
need lower tidal volumes. They need very
absolutely least
and early
damaging.
ECMO because the
Least
lungs need
damaging.
rest.
Right.
The lungs
So the
need
second question, if suppose the quantity drunk is really high, I mean that's very unlikely because it's such a pungent liquid that you cannot actually drink more than a few ml. But suppose the child has taken 50, 100 ml, is there that under intubation you can still give a stomach wash and remove the kerosene?
if you've protected the airway, you certainly can. But
Yes.
it's a volatile thing. So it is
Correct.
absorbed in many, many aspects. It will be absorbed from
Right.
the capillaries of the mouth. It will be
Mhm.
absorbed everywhere. So you certainly can try to wash out the stomach if you feel that way. I don't know if there's any role for hastening GI motility and getting rid of it that way. I'm
Correct.
not sure.
What is the general outcome? They all survive or most of
And
them survive?
nowadays they survive. Nowadays
Oh,
they survive.
and is there any, suppose those who had very bad lungs, you ventilated gently, they came out. Is there any chronic like fibrosis or something which
I would say
can happen with like paraquat?
Honestly, I've not seen a lot of them in the recent past, but I don't think it's as bad as adenovirus, frankly.
My,
Those
don't
adenovirus.
remind of adenovirus. Oh God.
Exactly.
Yeah, absolutely. Okay, Mihir. Samir, you want to continue or? Okay, so Dr. Mihir, let's come to the next organophosphorus. I mean, of course, when we were students, a lot of children and adults used to come. Nowadays, probably is not as common, but still, one of the commonest, what do you call, intentional poisoning in adolescents and adults, young adults, is organophosphorus. So, what are the products which are available in our day-to-day life which have actually either pure organophosphorus or in combination?
Yes, sir. So you are correct, sir. So nowadays we are seeing a less number of organ, at least in the tertiary care or the city, but in the rural area, if you say the rural Bengal, which are the district medical colleges, they get a lot of patient on the organophosphorus poisoning.
Correct.
And there are different compounds. They are used in for the mainly for the agricultural purpose. So there may be the agricultural pesticides, there are animal pesticides. So these agricultural pesticides which are used, they are very toxic, like parathion or the diethyl triclophos. So these are very toxic.
And they can also have paraquat.
Yeah. So no, the paraquat is different. There's a herbicide. They don't have the organophosphate compound.
In the farms,
They have different compound.
Correct.
Yeah.
So the common like rat poisons, insecticides, they are all organophosphorus?
No, rat is different, sir. Rat is this
Yellow
phosphate and they actually the coumarin effect. Though they antagonize the vitamin K and the bleeding manifestation. So that is a different thing.
How does one know this is organophosphorus poisoning? What are the pinpoint? You said already that a lot of bronchoria, gastroria, everything is secreting out, and pinpoint, not pinpoint, but meiosis.
Meiosis. Yes, sir. So if you look at this first, the history, the background, where the child is coming from is that this pungent smell, this the garlic-like odor in the from the mouth or from the clothes or in the face, you can get it, or sometimes the parents may bring the container. Then you can easily identify which is the compound, which is the chemicals. So that is important. And next is the toxidrome. So now there's always the patient gives all the secretions will be high. So there will be a lot of respiratory secretion, lacrimation, emesis, diarrhea, urination. So that will be there. And the patient have bradycardia, the bronchoria. So and they ultimately get the CNS and the respiratory depression and respiratory failure. So sometimes we get this fasciculation and muscle twitching. So these are the known features that if we get, we always suspect this the patient have organophosphate poisoning.
Correct. So there's a nice acronym you say, remember sludge and BPP. So sludge is salivation, lacrimation, urination, diarrhea, gastric, and emesis. And
MS.
BBB is bronchoria, bronchospasm, and
And
bradycardia.
bradycardia.
This, along with a constricted pupil and a garlic smell, there's nothing else
Yes.
but OP poisoning. How do you manage?
Combination
Yeah,
of
Dr. Sunu.
combination of muscarinic and nicotinic.
Nicotinic.
Absolutely.
can
So
be
what
quite
is the
complex.
what is the basis? And how does this poison really work as a poison? I mean, what does it do?
Actually, it inhibits the acetylcholinesterase that breaks
Correct.
down acetylcholine in the synaptic nerve synapses. So the
Correct.
acetylcholine remains there for a long time, and that leads to the hypercholinergic effect. And
Correct.
this treatment actually, as
Yeah.
a first of all, is the general management, that is the patient's resuscitation and stabilization. So
Perfect.
yeah, breathing, circulation, always you have to look for. And then the role of gastric lavage and the activated charcoal that we have already discussed. I'm not
Correct.
what we should go,
Now,
then I'm not again repeating
throw
it.
some light on atropinization.
Yeah, so atropinization is one of the important part because it will reduce the muscarinic effect or the secretions that drive. So you'd have to start with a bit higher dose, the 0.02 to 0.04 mg per kg, but maximum dose is children is particular dose is less than 12 years is the 0.6 mg. But then if it is more than 12 years, you can go up to 1 mg per dose.
And you
if
keep on repeating?
Yes, sir. If the end point is the dryness of the respiratory
Correct.
system.
Correct.
So that you have to repeat it and you can double the dose. Sometimes we require infusion of atropine as for a prolonged period because this opioid organophosphate compound, they have a long effect because up to 48 hours they can have an effect of this acetylcholinesterase enzyme.
Correct. When we were students, we were very fascinated by mugging a palm dam mina. So what is this palm dam mina or the
Actually,
antidote?
it's always better to give in the early phases to give atropine as an infusion. If
Absolutely.
they have the on-off phenomena,
Yes.
don't want them to crash and then give atropine. So
Correct.
better
Yes.
to give it as an
So
infusion.
I think we'll discuss the
And-
concept rather than dose because dose is something very difficult. Everyone should refer to
Just
because
refer
these
to
are
the
rare.
books. Yeah,
Absolutely correct.
absolutely.
So what are these
And,
other specific antidote?
Nitin, one point
Yes, please.
here is that it can look like a myasthenic crisis.
Yeah, exactly.
Exactly like a myasthenic crisis. And if actually we are supposed to be doing the pseudoesterase or the acetylcholinesterase RBC component.
RBC.
But
Is
the
it available easily?
pseudocholinesterase is equally good because it's much cheaper and available easily.
Correct.
And the different, if you are suspecting it, then the cholinesterase antibodies for myasthenia because it
So
can
Dr. Mir, what is
really
this
emit
antidote?
myasthenia.
Yeah, what is the
Yes, sir.
antidote?
Antidote, mainly this nicotinic effect, as Madam said, is the this is the antidote is the pralidoxin. So you have to start as soon as after you started the atropine. So along with that, then those you can check.
It's
because you
okay, we
may
won't discuss those.
remember
How long
always.
do you have to continue
Yeah,
sometimes?
so you have to consider it for a prolonged time sometimes because this up to at least 48 hours and then
Correct.
to check if it is reducing the dose, if the symptoms are again reappearing, then you have to continue for a prolonged time because this compounds which are very toxic, this diethyl component, they have a prolonged aging effect of the acetyl. So permanently they deform this acetylcholinesterase enzyme.
Okay.
So they have a prolonged effect. So that is the issue.
Can there be chronic poisoning because of OP?
There are two terms as the after the OP poisoning. There may be that is the intermediate syndrome that we say, that is the weakness of the proximal muscle, the verbal weakness. So that will be the another manifestation, and another is this peripheral.
Opin.
Yeah.
That is opin. So what is that? That's a chronic peripheral neuropathy like picture.
Yes.
Common is laryngeal nerve palsy.
Laryngeal nerve palsy. All right.
That is
So,
quite well described.
Correct.
And
Now
we've seen
again,
that also.
what's the outcome? Generally, they become okay if they come in time.
Yes. If it will come in the time, then the outcome is good. But if there is the already very late or there is child is always CNS depressed or coming whenever they have the very low saturation, lungs are already flooded, already 4 to more than 6 hours has happened, then the outcome may be poor.
Okay, let's move to Dr. Samir, you want to continue?
No, I think this is very important, but at the same time, something far more common, maybe not as sinister looking, but paracetamol poisoning.
Yes,
So
please.
that, like you mentioned, so I don't want to take the brand name again, but
No, it's okay.
paracetamol, people keep giving doses, and sir, you know what happens in that particular one brand which you mentioned, what drops ka.
Oh, you got muted again.
Muted, sir.
You got muted. Oh, Or is it the
Yeah,
connection?
and I'm saying
Yeah,
some of those brands, the
yeah.
concentration for the drops is different from the concentration for the syrup, and parents
Absolutely.
end up giving the stronger dose. And also for fever, the mother gives and she goes away. Father comes, बच्चे को अभी बुखार है, give one more dose. And sometimes it's quite, you do see a lot of. How often do you all see paracetamol poisoning?
Dr.
Anupama, ma'am?
Anupama.
Yeah, quite often, sir. Quite often, especially during the viral seasons, dengue seasons, the children get very high grade fever. Very common to parents to mix between kerosene drops with syrup paracetamol, and there's not
Mhm.
one single dose accidental dosage. It's most of the times a staggered dosage, which happens in especially in viral illnesses.
So what is the therapeutic maximum dose, Dr.
Uh,
Anupama? And like
around
in
one.
children and in adult, in mg per kg and in absolute
Yeah,
dose.
150 to 200 mg per kg in children. I think for adults is around 1 gram, I guess. The
Mhm.
1.5 grams
You
is the
said, I
toxic.
mean, you mean 15 mg per kg, not 150.
Yes, 15 m. No,
15
the
mg per
toxic
kg.
dose,
But
yes, the
no, I'm
toxic.
saying therapeutic
Dose
dose,
is
maximum
150.
Therapeutic
therapeutic,
dose is 15 mg. Yes, 15 mg.
maximum 5 times, so 75
Yes,
mg
fine.
per
Up
kg
to
per day.
75 milligrams per kilogram per day.
Yeah,
And in
yes,
adult, not more than 4 grams in 24
yes,
hours.
yes.
And
Yeah.
what is the toxic dose? You said 150 milligrams. That's like,
150 to 200 mg per kg. Yeah.
so there is a lot of window of therapy to toxic, like 10 times more. So I mean, unless it's accidental or a poison, like I mean, I don't know. We don't see paracetamol poisoning in
No, not
adolescent
that much.
so common, but Western country, that's the commonest poison in
Yes.
No
adolescent because it's so
longer.
easily
Common
available.
mistake, I
No
think my
longer.
experience I have seen that if you advise them over phone, if they have
Mm-hmm.
some drop, if you have advised give the 5 ml of paracetamol, they have the drop, then they
Mm-hmm.
give the 5 ml of drop, that is the each ml 100 mg, and they are giving the 4-5 times the drop as a 5 ml. So that leads to sometimes this high
Yeah,
overdose.
the basically the syrup and the drops which they get confused.
I understand. So, Dr.
And
Anupama, how do you, I mean, how do you how does the clinically paracetamol poisoning present in stages, and what do you look for at each hour
if
after
yeah,
poisoning?
if there is a history of accidental consumption, the initial few hours or 8 to 24 hours, generally they're asymptomatic. It's
Mm-hmm.
only after 24 hours they have symptoms of vomitings, and these are the initial first complaint they have. And then
Mm-hmm.
obviously when we do an LFT, we see there's a transaminitis. So the first phase is the gastrointestinal phase. The second phase is the hepatic phase, where you see a rise in the liver enzymes.
Mm-hmm.
And beyond that is this by day 3 and forward, the liver can progress to hepatic necrosis also. Some children
Yeah.
even they have renal failure along with
Yeah.
paracetamol poisoning.
Or even a multi-organ failure if left
Yeah,
if
yeah,
left
they can
untreated. If left untreated.
if left untreated.
Right. Okay. And then if suppose patient survives on his own, then he starts recovering after what, 96 hours?
96 hours, generally fourth to fifth day. If the drug is eliminated and the liver is able to metabolize it on its own, then yes, before to 6 day
And
it
this
will
is an
recover.
important message that first day the child may not have much symptom. Doesn't mean there is not significant paracetamol poisoning unless
Yes,
you have done the levels. And
yes, yes.
only after the first 24 hours that the liver abnormality, then the liver failure and the renal failure, and then something else will come into picture. So how do you go about managing such children?
If they come present very early within an hour to the emergency, yes, there's a role for giving activated charcoal if the consumption is in the toxic dose.
Mhm.
Beyond an hour, gently, I don't think there would be that much role. And it's as early as possible start N-acetyl cysteine. In our center, for us to send paracetamol levels and get it the report, it takes some time. So we start off N-acetyl cysteine infusion.
So
It's
you
better to
don't
start.
take the level immediately because it takes for time for it to be absorbed in
Yes,
the.
yes,
So
yes, sir.
what is
You
the
should
what is the ideal time to take the blood sample?
after 4 hours of
After
consumption,
4
sir.
hours.
Four
So
hours
that's a
of consumption.
critical sample. And
Yeah.
then you have nomograms to say at which hour, what is the level to decide on whether
Yes,
you need to keep.
yes, yes. There is a nomogram, but that is only for 4 hours to 24 hours. So beyond
Correct.
24 hours, if the consumption history is there, then the nomogram is also not useful.
As useful, correct. But in the
Yes,
first 24 hours, it is very useful.
yes,
So
yes.
you start anesthetic, as you said, at what level?
And give supportive care. And yeah,
No, at what
basically,
level you start anesthetic, you said, at 150 milligram
yes,
per,
yes, sir.
at
Yes.
150 microgram per
I
ml.
would, yes.
Okay, all right. And then how long you continue the dose?
We generally continue till we see the lactates being normalized and the INR being normalized. That is
Mm-hmm.
what we take as the endpoint to criteria. Some places they've given the liver enzymes to become normalized, but generally the
Correct.
lactates to normalize and INR to normalize. Yeah.
Okay, what will be the indication that this child now will likely to go into a liver transplant type scenario? What are the
There's a King's College
flag signs?
criteria. Yeah, King's College criteria for acetamine poisoning, and the criteria is quite strict. If there is persistent metabolic acidosis, pH less than 7.3, and with the liver dysfunction, they do go for transplant criteria.
Yeah.
Mhm.
In fact,
I always hear
one of our viewers, Dr. Abba
Akashdeep
Sahib
saying that
Patankar has
in the
mentioned.
sorry,
Sorry, Samir, Dr. Sunu is speaking. Let her
Sorry.
finish. Yeah, madam.
no, about liver transplant. Akashdeep at King's College, he has been saying for the last several years that they do not put acetaminophen poisoning on the transplant list because they all recover.
That's because they come in time and they are able to treat them in time.
Also, another thing, if they come early, activated charcoal is useful.
Correct.
Yes.
Of course, yes,
Yeah.
that we said. But if the levels are extremely toxic, like 900,000, probably these are the ones which are not likely to do
May not
only
survive,
with an
yeah.
sustained, right? So the best would be to prevent. So I think the tips are that when you prescribe syrup, just tell the parent they are syrup, not drops. Because drops are 100 milligram per ml. And if you say 7.5 ml, someone is giving 750 milligram every 4 hour, it becomes a toxic dose at the end of 24 hours. And the second thing,
One
yes.
other point, sorry, it's a very core intensive care point, and Anupama does a lot of it, so she might agree. A lot of these transplants are now actually avoided because we use a lot of CRRT in them.
Yes,
When
ma'am.
you put
Yes.
early CRRT and Plex and all that, you can
Yes.
actually avoid transplant.
Yes,
Sorry,
ma'am.
that's a very core ICU thing.
Yes.
So,
This
I
breeze
mean,
therapy,
sorry for
it's
my
in between
very
this
poor knowledge
medical
of intensive care, but the transplant is usually for a very damaged liver. How will CRT help to prevent that damage? Because it will
It
lead to
recovers. The
excretion.
liver
recovers.
recovers.
I see. That's very
Yeah.
interesting.
It
Okay,
Liver
recovers.
that's very-
recovers.
all right. So in an older child, the CRT is always very easy to do, not that
No
difficult, even
age,
in a
no age
hypotensive
limit.
patient.
No
Absolutely.
age limit. Now we
Yes.
do 6 kilos, 8
It's
kilos.
like
anything.
like a breeze therapy to give some time to liver to come out of the region.
Of course,
Exactly.
nothing to do with poisoning. But I remember we had a child in Hinduja with a small child who was diagnosed with urea cycle defect and was hopelessly sick. Dr. Sunu was not there that time. We had Dr. Umali, and then the child underwent CRRT because it was so difficult to do something else to bring the ammonia down. And then ultimately, he was the youngest to transplant by Dr. Rella. I think he was hardly 3 months or 4 months without any vaccination. That's the only way the child can survive. So talking about CRRT, there's no lower age limit. All right. So anything else in the paracetamol poisoning except that we should not keep too many tablets at home when you have young adolescent who is a little difficult adolescent because he can then use that as an intentional poisoning. Let's move to the next one. Dr. Samir, you can discuss corrosives.
Yes. So any special precautions when dealing in emergency with acid or alkali poisoning, Sunu ma'am?
Again, no gastric lavage, no trying to dilute the poison, no putting tubes down without knowing what you're doing. You will land up in the trachea or the lungs and you will cause fistulae. So very, very careful and early scopy to see the damage done. That's about all you can do in corrosive.
And how do you feed these children, Dr. Sunu? Because that's the
Exactly.
question.
Again, the problem with corrosive
So-
is the temptation to put a rice tube and feed. To
So
do a
instead of
gastrostomy.
gastrostomy,
Do a
correct,
gastrostomy. Because
correct,
really there is no antidote for these corrosives.
correct.
And
Never
the more
try
you
to,
try to do things, the worse you'll,
yeah, never
even
try to,
neutralization, giving milk and all doesn't work. Yeah.
actually, absolutely. Which is
Also,
which is more
when we
bad,
talk,
alkali or acid?
I think both are horrible.
Alkali is, yes,
Probably
alkali
worse,
is bad.
yeah.
Alkali is more bad
The
than
Because
other
it's
thing
acid.
is that
it's
when we think of
transmucosal.
corrosives, don't only think of drinking, because
Yeah.
even batteries and all are corrosives.
Yeah, absolutely.
Yeah,
So that brings me to the
they
question, Dr.
need to
Mu,
be removed quickly.
which are the common sources for these corrosives, like acid, alkali directly, but also like these dry cells
Dry
and then
cells, the
bleach
tiny
powders.
cells, they're all corrosives.
Yeah,
They're
they
Bleach
are all
powder, this drain powders, this
drain powder,
cleaners,
dishwashers, detergents.
dishwashers, yeah.
Yeah, they are
A
all, and they
bad
are
habit that we have is keeping our drain washers and all on the floor, and the kid is
yes.
crawling around, mother is busy, and they drink.
And the worst is to store these remaining washers in a normal bottle. So you
Yeah.
will also forget it is not a water bottle, it is actually a bleach bottle.
Absolutely.
So
Yeah.
that's
One
the thing.
important point is that the oral mucosal injury sometimes may be misleading. So there may be the very small or the no oral mucosal injury, but the child has ingested it. So do not rely on this oral mucosal injury. And another
Okay.
thing is that if there is some oral injury, this child are getting this laryngeal edema and this epic. So the airway obstruction they can get very rapidly within few hours of presentation. So preemptive the airway, if the child have the severe toxicity have taken considerable amount, then we may think about the preemptive protection of the airway in times of
One
intubation.
important thing, Dr. Sunu, role of PPI in the initial phase, because you don't want more damage to the already damaged stomach or the mucosal lining.
By that time, I think the external acid will, have such a high role that the internal acid, probably you can give PPIs and hold that a
Okay.
bit. But PPIs actually don't act immediately. They
Correct.
go through a cycle and they act. So,
Right. And
yeah, but
which is the earliest you will do a first copy to find out how much the damage?
I think it's supposed to be done within 8 hours or something to
Correct.
find out damage. Not immediately, but at least
Yeah.
6 to 8 hours.
24 hours.
And then they may need. Another thing is very often we are tempted to give steroids. The steroids
Correct.
do not prevent. In fact, they may cause more erosions, but they can help in the airway edema, but
Correct.
they do not prevent strictures.
So for the ones who have laryngeal edema and difficult airway, you can consider steroid, but not for
Yeah.
the
Yes.
It doesn't help in
esophageal strictures, because they
esophageal
are going to
strictures.
be treated more surgically by dilatation rather than by anything else. What's the ultimate outcome? They are like strictures form and they keep on needing dilatation every now and then, or is only a few times and that's the end of it?
No, they keep needing. Sometimes they have to have an esophagectomy with the pull through
Okay.
and all that. It's a bad thing. It's a
Correct.
bad thing.
Worst outcome is with the perforation. If there is there's mainly the alkali, they go to the esophageal
Yes.
perforation, the
And
mediastinal,
mediastinitis,
emphysema, then
high
everything.
mortality.
Yeah,
High
They
mortality.
need
prognosis is bad.
antibiotics and IV fluid and a
High
lot of
mortality.
managements like mediastinitis. Perfect.
Yeah.
All right. So this is one of the worst poisoning that can happen, not only because it leads to damage the airway and but also splash, skin, eyes, disfigurement, plastic surgeries in the future, etc. This is a terrible, terrible poison to have anytime. All right. Something that Dr. Meer asked the question that the gas geyser why we're discussing, Dr. Anupama, do you have any Meer, do you have any experience? Like we have a area in Bombay where there are more than 30, 40 deaths that have happened. And in fact, there's a
Yeah.
paper from that part of area. It's an area where gas geyser were very, very commonly used to save on energy or bill. So what is this gas
Yes.
geyser poisoning? What is the basis behind? And what is this gas and what is the poisoning?
So that is very interesting, sir. So I heard, I think the first time from you only. So this is, I don't have any experience
So
of
maybe
that.
I can answer that question.
No, it's an LPG. Basically, it's an LPG cylinder.
Yeah, so
And
people use
it's
instead
the
of electricity.
incomplete combustion of the gas that
Yes.
causes the blowout and the carbon monoxide. So
Carbon
basically, it's
monoxide,
carbon
right.
monoxide and other gases that's caused.
So
You have to
in
treat it like a carbon monoxide poisoning.
Right. So in an ill-ventilated bathroom, if you have put the gas geyser inside the bathroom, there's a slow release of carbon monoxide because of incomplete combustion. And carbon monoxide being heavier settles down. And without the knowledge, odorless, colorless, you start getting drowsy and then you don't come out. So if you bathe for more than 15 minutes in such an environment, there's a common cause. And people died. I mean, there have been couples have died, children have died without knowledge. So you have to have a ventilated bathroom or keep the gas geyser outside the bathroom.
Outside the bathroom.
So and this is also common in European countries where they used to use LPG gas to keep the house warm. It was compulsory that you cannot keep that in the house unless you have an exhaust nearby. I think that is, and Dr. Sunu, now that you mentioned, how do you, like suppose you have a patient suddenly coming like drowsy, he was found unconscious in bathroom or wherever, and then they bring to you and you do an ABG and you can.
Don't do an ABG, you first give him oxygen.
Then of course you give oxygen, but how do you know it is carbon monoxide poisoning?
So, there might be that cherry red color
Correct.
of carbon monoxide. The blood and the gas will show a very high PaO2, but the saturation will be very low.
Yeah.
And the color also will be peculiar. And now all our blood gases actually have co-oxygenation. So you can read it off directly on that.
So I think this is important that
oxygen,
you have those
hyperbaric oxygen.
Right. So you have this cherry red color. You have the plasma which shows like carbon monoxide poisoning. You have a high PO2, yet your saturation are very low. And if you look at the ABG down, you will see the carboxyhemoglobin. And that will tell you immediately give 100%
Sir,
oxygen.
sometimes the saturation may even be normal because the routine this pulse oximeter that we use, they cannot differentiate between the
Differentiate, correct.
hemoglobin and carboxyhemoglobin.
Yeah.
So
Right.
that is the misleading. And if you do the ABG with co-oximetry, this carboxyhemoglobin, you can
Right.
detect that.
So one more question to either of you: that is this the same reason why people used to suddenly die in the car where they keep the AC running during flooding and they don't realize there's carbon monoxide being released from the AC ducts?
So, another dangerous thing that we see people do in these hatchbacks, they keep the hatchback open and the kids are sitting there and enjoying the ride. And
Right.
the carbon monoxide, because of the effect of vacuum thing, the carbon monoxide comes onto them and they can get
Oh.
carbon monoxide. So these
Oh, God.
unsafe, in my lifetime, I think I've seen all these kind of incidents,
Correct.
children drinking cough syrup and getting alcohol poisoning.
Yes.
So
Correct.
Dr. Arvind Bhanumurthy is cautioning Dr. Mihir that it may not be common in West Bengal, but if you travel, make sure your Airbnb.
No, Samir, we lost your voice.
Airbnb?
No, if you go to an Airbnb type of accommodation in Bombay and you can have a gas geyser in your room or in your bathroom, and you be careful that either don't bathe for more than 5 minutes or keep the windows open when you are bathing in a gas geyser containing
That's
bathroom.
interesting.
No,
So
I think this is important because
we have this
it
electric
is such a
geyser.
silly reason to die in life. I mean,
Exactly, yeah.
heart-wrecking. I mean, I remember 1 year, 2 years back, before COVID, maybe 5 years, that a couple, just newly married couple, they were found dead in their house, and this was all. There was also one young brother and sister.
This was in
They
Kashmir.
just died. Yeah, no,
In Kashmir,
Mulund
this
area,
happened.
Mulund
No,
area
Bombay,
also.
Bombay.
Bombay, Mulund area. Yes,
In
yes.
fact,
So that,
in fact, there was a couple from the town where I am right now from Chiploon. They had gone there, and in Kashmir they had this. Both of them died. Yeah.
oh my.
Wow, that's
All right. So we are progressing to the next 2 or 3 poison before we take question from the people who are attending. Next is naphtha balls. So Doctor, have we lost her? She's there?
No, I'm
Anupama,
there,
yeah.
sir. I am
I
there,
think
sir.
she's gone out of the spots.
No, I am there, sir. There.
Okay,
Yeah.
So Dr. Anupama, mothballs or these naphthalene balls, they are actually not only naphthalene, sometimes they're combination. So can you throw some light on this as to how does it happen, what does it contain, and how does it lead to poisoning?
So quite common we see naphthalene compounds in them, and most commonly we see methemoglobinemia because of the consumption of these naphthalene balls. So we see children coming with complaints of vomitings, abdominal pain, diarrhea. Some of them throw seizures also. And then when you look, then obviously the saturations are low, but then you do a blood gas and the PaO2s in that are good, and then you come to a diagnosis of methemoglobinemia and then pick up a history of naphthalene ball consumption. Sometimes we see children with hemolytic anemia also. Whenever we see a
If they have
hemolytic anemia,
G6P deficiency.
yeah, they're G6P deficient.
Right.
But so this is what we see with naphthalene ball
But is this
consumption.
naphtha ball water soluble? Because many times, as an intention, people try to dissolve and drink that water. Actually, it's not water soluble, right?
Yes.
why do they drink it?
I don't know. That's what
As an intentional poisoning, someone will put
Yeah.
mothball in the water and drink that water, but it actually doesn't lead to poisoning because it's not dissolvable in the water. It's an organic solvent which you need to dissolve it. All right, some of them can contain camphor besides
Yes,
naphthalene.
naphthalene.
So
Yes.
how will a camphor poisoning come if it's a
Generally,
predominant camphor or pure camphor
seizures.
poisoning? Let's say someone just takes the camphor and
More of drowsiness and seizures. So there's a common presentation.
sinus
Yes,
irritant.
seizures. Yes,
But
very
generally they
sudden.
do well.
They do well, sir. They do, if just supportive care, they do well.
Okay, and how do you treat this naphthalene poisoning then if you have found a patient?
Methylene blue, the dose is 1 to 2 mg per kg. And we also give
As an IV
ascorbic
drip.
acid, IV drip, and we also give ascorbic acid for these children. So vitamin
And
C
how long you
injections.
continue till the time?
Till their saturations are better, and till your then we continue the methylene blue injection.
Correct.
You can check this methemoglobin level in
Levels.
the blood.
And yeah,
Yes.
methemoglobin levels also we can check it. Yes.
I think till the time they are less than 10, then probably they are
Yeah, less
asymptomatic. Yeah.
Yes.
And Dr. Mihir, this question is commonly asked. The camphor is part of a lot of food additives.
Yes.
No, there are food which have camphor. People who smell camphor, camphor lamps are there. So how? What is the dose at which, or is it just the pure camphor you eat and then only you can get, or even by inhalation you can get?
Inhalation.
It can be also by inhalation. So we had recently a patient with us after this attending a marriage ceremony. The child
Oh.
suddenly got this unconscious and state in a presented with the convulsion. And then suddenly when we did the ABG, we we didn't actually suspected it could be a poisoning, but when they did the ABG, it suddenly shows the methemoglobin level at 28%.
Oh.
So the camphor was that agent that why that with that
All right.
lead
So
to this
a lot of this pujas, they actually burn camphor on
Yeah.
leaves, and that toxic. Suddenly, if there's too much toxic fumes, also can lead to irritation.
Yeah,
I think like
and
that. All
it
right.
can cause an ARDS and anything.
Yeah.
Bumps,
You
yes.
know,
Yes.
another habit, not a habit, but a practice was that when the baby was born, they would do that dhoop and
Yeah,
burn
correct.
camphor and put the baby over that to clear the
Yeah.
lungs.
Yes.
I
Yeah,
think those
yeah,
practices
yeah.
are now not done.
I remember when I was working with Dr. Lokeshwar in very early life, in early practice, 86, 87, I'm saying. Diwali day, we were about to go out with my family, and I got a call from his hospital that one child has been brought very bad. And I went there and he was completely blue. And we said, we don't know what the cause of methemoglobin. Anyway, we treated with IV methylene blue, stabilized him. And then the history came that the grandfather was taking Dapsone for leprosy, and the child had taken mouthful of those Dapsone tablets, and that was the source. So sometimes you get all this type of funny poisoning in children who put everything in the mouth. All right, Samir, you want to take the lead poisoning? You are muted.
Go ahead, sir. Go ahead, sir.
Yeah, go ahead. Okay, Dr. Sunu, lead. The lead is not there in petrol. The lead pencils are not lead. Actually, they are graphite. There is
Graphite.
no paint. The old paints had lead, but now paints also do not have lead. So, what is the source of lead poisoning in today's time? Common as 2 or 3
Basically, it's air and dust.
dust.
Because
And
even paint is not supposed to have lead.
yeah,
But a warning on that is when we buy
Hmm.
cheap toys, children
correct.
will eat those toys. So be careful of
So
these
the spurious drugs,
spurious drugs contain, Ayurvedic medicines contain
medicines.
air.
Yes,
And so look at the air quality index and look
correct.
at the particulate matter.
And lead contamination of
is
water.
and
Lead.
lead. So when your groundwater contains lead,
Yes. Yeah.
those old lead pipes.
Yes.
I think now most buildings don't have
Yeah.
them.
And it is said that
Sindoor
old houses, people staying in 40s and 50s
So-
house, and child has pica, the old flecks of paint which
So
have come
if
down,
you
the child can
remember,
eat.
we used to use something called oil paint in the past.
Yes.
You may, in my childhood, there was always oil paint,
Yes,
especially
yes.
in the kitchen, so you could wipe it off.
Right,
That
right.
contained lead.
Correct.
All those
And
things are now gone.
yeah.
Mainly it is from the water, from Ayurvedic medicines, and
Yes.
where
Yeah,
your
I have
ground is heavy.
Sindoor is one of the things that
I had a family of lead poisoning, Dr. Mihir, and they were father of that family. The main person was a goldsmith, so his business was to distill gold from the dust.
Yes.
So he would collect kilos of gold dust from the gold factory, and he distills, so he gets a gold lump. To distill the gold from this, they need to use lead. And those lead vapors, if they don't go out of the house, it can lead to, as Dr. Sunu said, as the inhalation. And the simple thing, putting a furnace over that thing that where he used to distill the lead from the dust, the kitchen furnace, which throws the exhaust out, and that solves the problem besides treating them for the lead poisoning. So simple things which can
simple
happen
things
and
like
it
that.
can lead to. So when do you suspect lead poisoning, Dr. Sunu, in today's time?
It is a most complex thing. Your index of suspicion has to be high, and
But
basically
few
the
common toxidromes.
abdominal pain
Yes.
and developmental delay or regression.
Perfect.
Child is getting dull, a little silly, stupid. I mean, I'm using stupid words. But
Encephalopathy.
basically, yeah. Encephalopathy will be a very last and high stage.
And anemia.
So anemia again, plus minus. In the past, I remember when I was training in the US, we used to do just a hemoglobin on all children between the ages of 6 months and 2 years.
Yes.
But now they do with the same finger prick, they do the plasma
FEP.
lead level. They don't
Yeah,
do the
correct.
hemoglobin anymore because
Yes.
hemoglobin is quite, and in our country where 60% of the children are anemic, it would not help us. And that basophilic stippling and all doesn't really, very late stages. So,
Yes.
yeah,
Free
and
erythropoietin
don't try to take X-rays and see lead chips in the abdomen. You're not going to see that.
Correct.
So,
We used to do a lot of FEPs in the past.
neuropathy, mental deterioration, not doing well in school, chronic abdominal pain, things like that. Finally, the kidney, liver, everything can be affected because it's a heavy metal.
And the worst
It
part
is
is that
not
the
easy.
lead gets trapped into the macrophages and it never comes
And
out.
bone, you can get bad
And the
bone
bone.
pain because
Yeah.
it's these heavy metals go straight into the bone. So you
Correct.
can get bad bone pain.
And remain
And
then
if
for
you look-
years.
Yeah. And you get those lines, those sclerotic
lines.
lines. That
So you get
lead
lead lines in the gums, you get lead lines in the bone,
Yeah.
you get lead lines in the RBC in the form of vasophilic stippling. That's how we used to. So A to Z of lead poisoning. We used to anemia, vasophilic stippling, caboting,
But we
dementia.
never saw any. We mugged it up, but we never saw any.
Yeah, but we never saw.
But
Correct.
even the treatment is not easy
Correct.
because you
So
have
what's
to
the
give
management?
EDTA, which luckily now is available in its IV and oral form because it's now linked to antibiotics. But many antibiotics come with EDTA, so you do get EDTA now, and you can actually give it in the oral form. But dimercaprol and all, very, it's gone out. It's actually gone out.
And
It's only
D-penicillamine?
EDTA. Yeah. A lot of people, advocate bananas, milk, all that, but those are all adjuncts.
So at what level of lead will you consider treatment in an asymptomatic patient and a symptomatic
Actually,
patient?
nobody should have any lead in their body.
No,
in
but
their
there is
blood.
always lead in
Yeah.
everyone's body. That's the
Yeah,
question.
so I think I wrote it down somewhere.
Okay.
3.5 micrograms per deciliter is treatable.
Correct.
Is
So
treatable.
anything about 3.5 is
So you should
high.
actually be, below you should be.
Correct. And anything more than anyone who's symptomatic
Anybody who's
with any lead
symptomatic.
level should be treated.
And I think now you can get lead levels done in many laboratories. So that's
Correct. Last part, Dr. Samir, you want to take the drugs,
Yeah, so
accidental drug
now
injections? Yes.
quickly we need to go
So take one.
rapid
Yes.
fire. So about mosquito repellents, Dr. Mihir, what is a toxin? What does it do, and have you had to manage it ever? Mosquito repellents.
Yes, so mosquito repellent, actually this is a combination again. So this is the pyrethrin and the kerosene as a solvent. So
My.
this can give both the effect. So pyrethrin is basically the CNS effect. It can go to the irritation, then convulsion, and this kerosene you can lead to the again the CNS and the respiratory.
Perfect.
So it's basically again the symptomatic management and the supportive management. No antidote is there. And gastric lavage, as is sometimes called the kerosene, the gastric lavage is avoided.
So someone is the mat, mosquito mat, the repellent mat. What happens? Same thing?
Liquid mosquito is this, liquid repellent is this pyrethrin. The mat exact component, I don't know this, if it is contains the same or not. I don't have
I
an
think the
idea.
mat, they say the concentration is so low that actually
Okay.
it doesn't matter even if someone has chewed a little part of mat. All right, next, Samir.
Now, so we'll go to Dr. Anupama quickly.
Yeah.
Anti-diabetics.
No, 1 minute
Yeah,
before that,
anti-diabetics.
sorry, 1 minute. Let's discuss the morphine because still in small babies.
Yeah. So about, have you had any poisonings with morphine? What are the common sources? How do you suspect it? What is the specific intervention for morphine?
Morphine, again, I think the context again. So adolescent age group, then the patient were admitted for giving the morphine as a pain relief medication, suddenly accidental overdose. That is the one group of patient. Another group of patient is the recreational drug use, that heroin that leads to the toxicity. And so this patient, the manifestation could be starting from initially this hyperactivity, this dysphoria, then later on depression, then CNS depression, and ultimately respiratory depression.
Constipation.
Yeah, the gastric
And
motility.
absolutely pinpoint meatus, pupil.
Pupils.
Yeah.
Also, I don't know when we are going to face a fentanyl epidemic.
Absolutely.
The West is facing it in a very, very bad way. There are hundreds of deaths with fentanyl.
Yes.
Fentanyl is even more dangerous than pure morphine.
Yeah, because the concentration, it's 100 times more. And the other thing is, if you're facing an addict who has overdosed, be careful when you give naloxone.
Correct.
Because it can precipitate seizures. It'll act like a withdrawal and precipitate.
Yes, you have to be very careful. Yeah. And if you keep on giving too much naloxone, it can also have an agonist effect. Or was it seen more with nalorphine?
I think the nalorphine is the most
Nalorphine, yes.
yes.
Naloxone is a pure antidote. Nalorphine
Pure
is
antidote.
both antidote as well as a partial agonist. So be
Partial
careful when you use nalorphine. All right, next.
Okay, so quickly now, Dr. Anupama, have you faced any kind of poisoning with anti-diabetic
Yeah,
medications?
yes, quite common with metformin. So they
Mhm.
present with metabolic acidosis, and if the dose is very high, they would need even a dialysis for metformin. So
Oh,
yeah, and hypoglycemia, they present with hypoglycemia also.
and
Sulfonylureas, there's a role for giving drugs like glucagon.
yes.
Yes.
Yeah, what about antidepressants?
And tricyclic antidepressants poisoning we see. So children do present with cardiovascular issues as well as metabolic cirrhosis. So we give them soda bicarb, do an ECG, look for the changes, and sometimes if the dose is quite toxic, we do dialysis to remove the drug.
What
And there
about
is
Easily
So
removed by
one important thing is this TCA depressant,
dialysis.
the defibrillator, if they're coming with the cardiac arrest, the defibrillator usually does not work. So you have to give soda bicarb that Dr. Anupama has mentioned. So
Okay.
that's an important point.
what about antihypertensive overdose?
Sometimes we see with clonidine overdose. Sometimes we see the regular beta blockers, calcium channel blockers. So basically, they need monitoring. If they're in shock, then they need to be supported with fluids and vasoactive agents. And ECG monitoring is what most of these children need.
And really
Okay.
pacing.
Sorry?
Really pacing.
Yeah.
If they're
Yes,
very
yes,
bradycardic and a
yes.
hemodynamic compromise, pacing
Yes.
overcomes that.
Yes.
Unfortunately, we are seeing a large number of prescriptions for clonidine now, especially the children that I
Yes.
see.
Yeah.
And psychiatrists are very fond of prescribing clonidine.
Yeah.
But we must keep in mind, especially children who have special needs, they can have some of those really bad days that the child has a bad day. The parent is chronically stressed, having a bad day. And sometimes I've seen parents just kind of give more clonidine just to keep the child quiet because it's really beyond a level. Be very careful when you give all these medications, especially the antipsychotics and the antidepressants. So now we're going to this again general principles, unknown poisoning. So eventually we discussed this, and like sir said at the beginning, nobody comes with a label of poisoning. If parent has told you that this has happened or is detected that those tablets are missing, that's fine. What happens when you have an unknown poisoning? And I would like you to give a specific example from your practice. Did you have a child who came in with some symptoms and you didn't know it was poisoning, and how did you then come to the fact it was poisoning? What did you do to find out what the poisoning was?
Who are you asking?
Each one of you. One rare
Yeah,
poisoning that she can talk about thallium family.
The thallium was easy because they came with the diagnosis of thallium toxicity. Adults had got it and the kids were admitted with us. No, but recently, last month, we had an adolescent girl who suddenly in school fainted. First, they thought she had just fainted, but after that, she became progressively obtunded to the point where she was admitted in a hospital. She was intubated, ventilated. Then she got better, and the tube was removed. She was talking, everything. Suddenly, she again had a respiratory arrest, tachycardia, and they had to reintubate her. After 5 days, she was transferred. We couldn't make out what was going on. She was absolutely obtunded. When she came, actually, I thought she was brain dead. She had no brainstem signs at all. But the guy during transport had given her a lot of atracurium and fentanyl. So we waited. She woke up and she was good. She absolutely woke up. She was fine. She was talking. She wanted to eat. We extubated her. About 4 hours after extubation, suddenly she started frothing. Quite suddenly, she started frothing at the mouth and like a pulmonary edema. And she started sweating. So the resident who was there in the ICU called and said, something is happening. We are we are reintubating her. By the time I went there, my associate, Dr. Ion, was there. He said, this looks like organophosphorus poisoning.
Oh,
And it was organophosphorus poisoning. She had intermediate syndrome.
oh,
So,
oh, I see.
the penny dropped like 6 days down the line that this was
Bye.
organophosphorus poisoning.
Oh, okay. And by the time the critical period to give antidote was over,
No, actually, she got better.
she got
A
better.
while. She took a
Oh,
while. But
Oh,
we
yeah.
even gave her PAM, even though you're not supposed to give PAM.
That's what I'm saying.
Yeah. But we did give her, and she actually got better.
Okay,
So
Dr. Meir,
that's
anyone?
interesting. Dr. Meir, anything that you've seen, unknown poisoning, and then you discovered? Dr. Meir, Dr.
Unmute,
Anupama.
unmute,
Yeah,
unmute.
yeah. So this one is the Camphor that incidents I discovered. And then sometimes this patient, though it is not poisoning, but yes, this neurotoxic snake bite, sometimes they
Oh,
as
yeah.
yeah. So the patient suddenly become this respiratory paralysis and middle of the night and the early morning. So these are the group of patient.
We had a full 1.5 hour webinar last month
That's
on bites, so
Yeah.
everyone is a little fresh with that. Dr.
Dr.
Anupama?
Anupama?
We recently had a child. She presented with high-grade fever, and she was managed outside as meningoencephalitis. The hospital has done an MRI, and with the current trend to treat children with steroids, she was also given a dose of steroids, thinking that it is meningoencephalitis, autoimmune encephalitis. So the diagnosis was jumped to autoimmune encephalitis. She came to us. She just had seizures, fever, and as Sonu madam said, an encephalopathy not explained by neurological symptoms. She was drowsy. So here also CSF analysis was done, an EEG was done, an MRI was done, an autoimmune panel was sent, and all turned out to be negative. But then, since she was in the ICU, what we noticed is she was having intermittent ventricular ectopics, and the story and the clinical disease which we were thinking were not matching. So we just said, why don't we just send for poisons? I mean, it just because looking at the ventricular ectopics, there's some gastric dysmotility also, and an encephalopathy which was not explained by CNS disease. So that turned out to be a carbamate poisoning for her.
Oh,
And sometimes organophosphorus is a very nice mimicker for brainstem encephalitis, meningoencephalitis, and it does get missed sometimes.
yes. Before we wind up, Dr. Meir, you want to discuss paraquat poisoning?
yeah.
We-
Dr.
Dr.
Meir.
Anupama. Yes, so
yeah,
paraquat, I think
Yeah,
the
anyone, either of you.
child.
Yeah.
we recently had a child with AKI. So
Uh-huh.
then she initially presented as AKI. But then when we opened and saw his tongue was complaining of dysphagia, he had the typical ulcer of a paraquat.
Correct.
And then subsequently on probing on Holy Day, they had mixed the colors in the one of the bottles, and they were spraying against each other. So initially, but we lost the window to do heme absorption for the child because he
Correct.
presented almost for 6 to 7 days after the incident. Luckily, he's still surviving. He has some lung involvement, but he's been discharged home and he's surviving. Maybe the consumption
but-
must have been not more.
But can have devastating pulmonary fibrosis, which can
Yes.
Yes,
behave like an
sir.
ILD.
Yes, sir.
Okay,
ILD, the
poisoning,
lung
if you
necrosis.
survive, it's a case report.
Yes,
Absolutely.
yes,
Yeah,
yes.
survive. Yeah, literally, it becomes a case report.
All right, we have
It's
5
very,
more
very
minutes.
bad,
We have
yeah.
5 minutes. We don't have any question in the chat box, but someone has said that very small children being loaded with sweaters which are put in naphthalene balls itself can lead to a lot of inhalation and a poisoning like picture. So that's true, Dr. Amin Kaba. What you say is right. Last 5 minutes, if we have not discussed iron poisoning, and it can happen sometime. Yes,
Yeah.
Samir.
While we are discussing that, I would request all the experts to write down the numbers or contact numbers. Like Madam can share if you have any numbers, or Rainbow Hospital you can share, because all our viewers want to know if you can share the phone numbers of the emergency centers to contact. Yeah, please go ahead
So
with the
she said Amrita Institute, I think people can find out online. AIMS
Okay.
is online. Hinduja, of course, everyone knows the number. So these are the 3 or 4. And of course, I would strongly suggest an online up-to-date like program, which is really up-to-date on as far as poisonings are concerned. So
Yeah,
iron is something which you have not discussed. If anyone wants to like to discuss, Dr. Sunu, you have seen any iron poisoning?
No,
I had a child who was prescribed, I won't name the
Yes.
brand, but it had 250 milligram of elemental iron per 5 ml TDS for 3 months. So that was like in a 10-kilo child, if you take 750 milligram per day of elemental iron, what can happen? So iron poisoning, when you suspect, and because there's a specific antidote in the form of desferrixamine which you can
Yeah.
use.
Yes. So mainly initially there may be some abdominal pain, vomiting,
Yes.
like that. After that, again, like this paracetamol, there may be some
Pulmonary.
pain. Yes, there will be no
Yes,
symptom. That then again after 12 to 24 hours, this hepatic failure, the patient will come with the hepatic failure, bleeding, the necrosis, liver necrosis, all the things. So Then this thing, I cannot remember the exact label, but that label can be done at the iron level. That can confirm the diagnosis, and if we cannot do the label, I think the some literature says the acidosis and bicarbonate level corroborates with the this iron toxic level. So if the patient have severe acidosis and the bicarb is less than 15, then that corroborates with this iron toxic
Perfect.
level. Yeah.
And then infusion of desferrixamine for next 24 to 40 hours will solve the problem. All right, I think we have discussed a lot of general.
One
Yes,
question:
Dr. Sunil.
any role for whole bowel irrigation in any poison, iron poisoning, etc.?
Yeah.
Anyone has experience, Dr. Anupama?
I think for anti-epileptics, I think, but I have never done so.
I
Resorted
think
to
it's
that.
capsulated and
Capsulated.
enteric-coated preparation, which
Yes.
out of stomach but staying at the intestine, they have some role of the whole bowel irrigation, like iron or enteric-coated tablets, so they can have some role.
Yes.
Okay.
I think
Sum up,
we've
Dr.
had,
Samir.
I think we've had some wonderful discussions. As a comment by Dr. Sharma, how do you approach child abuse and neglect in a case of accidental poisoning? Whether there's any protocol to follow? So I'm sure that must also be a worry, whether it's a case of neglect and whether you need to make a medical legal case about it. I think in all
So
cases,
all poisonings have to
Yeah.
end with counseling by a counselor, both for the family, if they have kept something on the for a very small child who could accidentally take it, or for intentional poisoning, obviously a repeated counseling will be required to prevent further
Yeah.
episode.
Another very important, more than a question, I think it's food for thought by Dr. Pooja. How do you manage a mass poisoning? Any specific things to consider? So,
Mass?
mass, MASS.
Yeah,
Mass.
Samir, if I
In the school,
remember,
children have consumed
Mass
Nerve poisoning.
poisoning.
Nerve poisoning.
Do you all remember holy days when they used to use aniline dye and a whole lot of children would come with methylene blue?
Methemoglobinemia.
Yeah.
I
Sorry,
think
not with methylene blue, with
Jagrut is also
methemoglobinemia.
asked what happens if a
Those-
child consumes a mother's lipstick. I think the mother needs to get another lipstick and keep it away from the child. But the real problem is nowadays they're making all these videos on and reels of children wearing makeup. I think that's another topic that we have discussed, but I won't go into my social pediatrics right away, but keep the lipsticks away. And also with this e-vaping and all, I think we'll do this in addictions next time. I think it's been a wonderful
Samir, just
discussion.
1 minute. We have Mahesh. Mahesh Mohite. I've heard him speaking on poisoning in general many times. You have anything to add, Mahesh?
Yeah, I think they have extensively covered. I mean, since you asked me, maybe one thing which has come up now, you asked about the alkali batteries. So every
Yes.
alkali
We
battery
didn't
has to
discuss
be
that.
removed.
Right. Go ahead.
Every alkali battery has to be removed. Until the time you remove, there's something which is evidence-based now is to give honey. One spoon
Correct.
honey every 2 hours. That
Oh.
coats the battery and prevents the electric current going to the mucosa. And this is evidence-based. There is enough evidence for that. As far
Correct.
as the corrosives you already said, I think Mihir has very rightly focused that even if you suspect smallest amount has gone, so even if you suspect slightest airway compromise early signs, preemptively intubate this patient for 48 hours till the time that because once that edema happens there, God save you, you cannot intubate
Yeah.
that child. You have to do
Perfect.
trachea and
Perfect.
scopy either within first 24 hours or after 2 weeks. No
Correct.
scopy in between time. And very important, never put blind NG tube when there is a corrosive. Never.
Perfect.
We had a case in Vadia which came to us after 3 days with clear mediastinitis because somebody had
Oh.
pushed in a NG tube after the thing. So never put blind NG tube. I think rest almost everything you have covered, muscarinic and nicotine and all. You need to, for understanding poisoning, you need to understand the physiology very well.
Absolutely.
All those toxidromes we talked about are totally nothing but physiology. So
Correct.
nicotinic effect and muscarinic effect, and small dose of OP will give rise to muscarinic, which is actually a post-sympathetic or post-synaptic parasympathetic. The small dose will cause. And
Correct.
nicotinic is nothing but the proximal synapses, which will be in skeletal muscles as well as autonomic system. And those are the ones
Perfect.
caused by larger doses, and that will lead to cardiac failure, hypertension, and pulmonary edema and all those things. I think the rest, everything is very, very extensively nicely covered. Few of the things even I didn't know, honestly. So it was wonderful.
Very
It was
wise
wonderful.
words from Mahesh, who
Yeah.
I'm sure manages a lot of poisoning at a peripheral level and does some human services to children from far off places beyond Bombay. All right,
So
Samir.
back to basic, back to first MBBS for physiology, second MBBS for pharmacology and toxicology, and that's where all the science lies. You said God save us. So two comments. One is that very often these cases can end up creating a big confusion between the patients and the consultant inside. So be very, very careful. You need to have refer to all these centers, as we mentioned, call out to the experts. But if you are worried, because for the parents also, they don't know what's happened, and then it's quite possible for them to think that the child was not so bad, but after coming to the hospital, it's become very bad. And you are going to face a very, very serious music for absolutely no fault of yours. So this Zara Hatke, Zara Bachke is also a message to all of you that if you have a case of suspected poisoning, parents are unlikely to believe it, because it may happen that the father may blame the mother कि तुमने बराबर से देखा नहीं बच्चे ने इसलिए वो पानी या वो पी लिया. So it's always, she's never going to tell you that this happened then in that case. So one is always be careful about guarding or watching your own back. Call up your colleagues, have your colleagues over. That's point number. Point number two, which I think we have to probably another session on, is we have talked about everything inside the ICU. We have not talked about the persons outside the ICU, and that is the parents. उन पे क्या गुजरती है? What are they going through? Because very often, what is the most important thing is guilt. Because they felt, oh, I shouldn't have left it here, and then the mother-in-law is always there to add the further point, ki, you shouldn't have left it here and things. And that poor mother is now thinking that दो लोग probably मरने वाले हैं, वो बच्चा और मैं भी. So that is a kind of mental stress that parents are going through. And as we said very often in OPC or something, we are not sure. We can't say for sure that the child is going to come out of it. So it's very important to understand that one of your team members, if not you, needs to be talking constantly to the parents. Again, it's a sudden event. So it's not that all the relatives will gather at once. The mother may come running. The father is at the job. He may come 4 hours later. Then they call that uncle who's a especially troublesome fellow, etc., etc. So you need to keep managing their psyche outside, because you can't really blame them, because they saw the child hale and hearty and then they don't know what happened. So the guilt is what the parents are going through, because very often they feel it is their fault that the child ended up consuming those toys maybe, or whatever else you said as lead poisoning or whatever. So we need to understand that guilt is a very large part of this part of medicine. Maybe you don't feel guilty if somebody got a pneumonia or something, but here you would. So it's very important to have a word for the parents, have a kind hand around their shoulders. And I think all of us will be much, much better off. Thanks once again, not just to our three wonderful experts and Nitin Bhai, but everybody who logged in, and all of you, including my dear friends here from Chiplun, who do a great job of handling all patients who come to you in emergency care and taking such a mental beating yourself, all the stress that all of us go through to make sure that any challenge in front of you is solved. So you are all the Dr. House MD, one of my favorite web series, where you go out of your way to find out what's going wrong with the child, and you spend sleepless nights working for the child. Hats off to all of you. Thank you very much. This is Dr. Sameer Bhai and Dr. Nitin Shah. And thanks to Dr. Sunudani, Dr. Mihir Sarkar, as well as Dr. Anupama, as well as my dear friend Nehal, and everybody from IAP Mumbai for facilitating this. Mahesh, for your comments. And all the wonderful comments in the delegates have been so participative today. Thank you very much. We'll meet you again next month with the next episode of Zara Hatke, Zara Bachke. Thank you very much.
Thank you.
Excellent.
Thank you.
Excellent.
Thank
Thank
you.
you.
Thank
Dr.
you.
Nehal, you want to say something?
So on behalf of IAP Mumbai,
Yes.
Jagruti is going to give a little vote of thanks
Oh,
in a
yes.
Zara
Sorry,
Hatke
Jagruti,
manner.
sorry to do that.
Yeah.
So she will thank formally the moderators as well. Jagruti.
But I again publicly say this brigade of women at the helms of the affairs of IAP Mumbai are tremendous. I mean, I can't believe it, really. They can beat anyone, I mean, including myself. I always thought I am a very able
So you are
administrator,
unbeatable.
but they are really very good. Yes, Jagruti, go ahead. Sorry.
Thank you, everyone. Especially our heartfelt thanks on behalf of IAP Mumbai to our experts of today, Dr. Sunudani, Dr. Mihir Sarkar, and Dr. Anupama Yera, who have garnered interest of more than 150 pediatricians for 1.5 hours on a busy weekday. It is said that gratitude is the hardest of all emotions to express. So it is difficult to express thanks to our own Dr. Sameer Dalwai and Dr. Nitin Shah, who has actually taken us through the entire A to Z of toxicology. It's like learning an entire chapter from Nelson, and much more replete with a lot of mnemonics and clinical presentations and management protocols. And of course, Dr. Mahesh Mohite, who gave his expert tips. We all know the kind of practice that he has, which would probably involve a lot more poisonings than all of us put together in the city of Bombay. So thank you so much, and all the delegates for being there till the end. And please keep blessing us and being a part of IAP Mumbai Monthly Connect, every Wednesday, every second Wednesday of every month. We will definitely come with another exciting chapter in the next month. Thank you so much, everyone.
Thank you.
Thank you, everybody.
Thank you. Thank you.
Good
Thank you.
night.
Thank you,
Baba
madam.
Saheb,
Thank you,
so
Sonal
much for
Dani,
your
madam,
comments.
Dr. Yera.
Baba Saheb.
Thank you, Samir bhai. Thank you. And
Thank
thank you,
you.
Nehal. Thank you all. IAP
Thank you,
Mumbai.
thank you,
Thanks a lot. Bye. See
thank
you.
you so much. Thank
Definitely
you, everybody,
connecting
for
next
joining.
time. Thank you.
Thank you. Bye. Bye.
Nice.
rat bites, rat poison, rat.